you were already introduced as the CEO of Centene, but for folks who are in the audience who might not actually know what exactly Centene is, do you want to share a little bit about Centene, what you guys do, how big you are?
Yes, I admit that we're probably one of the largest healthcare companies most people haven't heard of. When I told my husband I took a job at Centene, he was like, "Is that the gum?" No. So, note to self, branding issue. So Centene is one of the largest managed care organizations in the country. We serve a little over 26 million Americans, started in Medicaid. So we operate Medicaid managed care in 30 states and are the leading provider of marketplace, so individual products, ACA products in the country, and then the 6th largest Medicare Advantage player. So across the marketplace and MA footprint, we're in 50 states and then again in 30 states for Medicaid.
Awesome. It's a big company. So you have definitely a different profile and background from most of the CEOs who are operating the large health payers today, coming from venture, the startup world. How has that prepared you for the role that you're in? How does that change, you think, your viewpoint in terms of where you're focusing inside Centene?
Yeah, I get asked that question a bunch. And there are two kind of interesting, I would say, threads that have been incredibly valuable to me in taking over the role. One is actually having grown up in startups and growth organizations. Centene is a $130 billion startup in many ways. It's an organization that was led for 25 years by a de facto founder, Michael Neidorff, who is an amazing visionary about, and in some ways that team sort of really created belief and structure and proof points around the Medicaid managed care model. But because of that, it grew up in a lot of ways the way a startup grows up. And it's an incredibly local company, very, very agile. And the way that we've grown over the last 10 years was through large-scale acquisition. And so we have this interesting dynamic of being incredibly entrepreneurial and innovative, and now being 70,000 employees and $130 billion, and like, how do we bring those two things together? So I've seen that same inflection point and lived through it in smaller companies, and that feeling of how do you grow into your scale and think about, I used to joke that being an operator in a startup is like, I did it. Why do I need to do it again? I got it done, right? I did it, great. Being an operator in a scaled company is how do I do it again and again and again and better every time? And at the same time, the magic of that innovation and the entrepreneurship and the local ideas and the ability to like swarm a problem and just solve it that you feel when you are in the trenches in a really small company. How do you make sure you preserve that? And so I would say, we're very lucky in that the company is extraordinarily mission driven. I think that's sort of at the heart of the answer to that question. But that has been one piece, is sort of having that pattern matching experience. And then the other piece is coming from more of a, I get painted a lot as coming from a technology background. You don't want me choosing your technology. I come from a data background, right? Like, I'm a huge data geek. That's how I grew up in healthcare. I credit Tim Berry with that when he gave me my first job out of business school at Accretive Health. He said, if you understand healthcare data, this was a bunch of years ago. He said, if you understand healthcare data, that will position you so well over the next decade because of how the world is going to change. And then he threw me into a team of actuaries, English major. I taught myself how to code SQL and pull clinical data out of early EMR databases. And that lens, which I know we'll talk a lot more over the next 24 minutes. But that lens helped me see how healthcare has been evolving over the last 20 years in a different, in sort of like an underpinning way, right? Like, how are the plates shifting, not what's sitting on top of them? And I got the wonderful experience when I was at Humedica of seeing what did the advent of clinical data do to how we were looking at populations and how we were understanding risk and even clinical care in a fundamentally different way. And then how did life sciences play into that, right? So how can these things all connect? And And so coming into a large payer where I think we have this opportunity for transformation, I definitely bring a perspective of, how do we first harness our own data? And then what can we actually bring to bear to change the industry the way it needs to change because of that experience and that lens through data.
Yeah, and your member population is distinctly different from any other payer. For folks who don't know, and you can correct me on this stat if it's now outdated, but 1 in 3 births in this country are Medicaid. I actually think it might be 1 in 2 now. That means that you have to look at data differently. It means also that you have highly vulnerable individuals in your patient population. When you think about that overlaid with the broader context of data, the fun ways we think about it in healthcare, what does it mean for you? How are you thinking about kind of preserving and protecting the population that's dependent on Centene for access to life-saving care?
Yeah, I mean, in some ways, it feels like the pessimistic view, right, is that we have a long way to go. We have a lot longer way to go than we think we do, and the reality is we still have a really long way to go relative to how this industry needs to be operating with our data. But if you think about the fact that the Medicaid population, huge swaths of that population are managed through FQHCs. FQHC is highly variable in terms of technical sophistication, the ability to then invest in getting the data out of those transactional systems and figuring out how to make it usable, right? So all the things that I'm sure many people in this room have spent many years trying to figure out how to enable in a commercial cost structure, right? You're figuring out how to do without any of the margin to support that, and sometimes not even the skill set. So we have just huge gaps in terms of understanding the care in those populations. Then the interesting part is sort of the next horizon of data, particularly for that member base, which is data around drivers of health or social determinants, right? And so one of the things we talk a lot about is what is the data that you get not from the 80% that influences the 20% of medical outcomes and clinical outcomes. And those organizations, the community-based organizations, are at times even less or way less sophisticated even than the FQHCs. But the idea that they are delivering, food and housing and job training and childcare, and that understanding how those inputs actually influence the overall calculus is going to be critical to how I think we tell the right investment story over time for the Medicaid population. And that data is worse than Swiss cheese right now.
Yeah, I think it's definitely, we're seeing more and more narrative, and I think we've seen this consistently with health data, that there's social determinants data available, that it's better, that things are getting better, but in reality, each of those institutions that are serving that vulnerable population they still do not have the most advanced technology. They're not building standards-based APIs. They're still doing things on paper. There's still a long, long way to go.
Yeah. Well, and even the social determinants data, when you really dig into well, what do you mean when you say that? It's zip code and race and ethnicity. And that's great. I mean, honestly, that's a start, but it's not even close to what are the other services. I mean, we were, I'm not doing backwards math very well, but call it 15 years ago, at least 10 years ago. One of the things that Humedica, marketed itself on back then was we've got all this clinical data and we're building some of the first predictive models with scaled normalized EMR clinical data, right? And we built a pediatric asthma model. I think we're far enough away that I can tell people what actually was in the model now. We weren't used to not be able to tell people what was in the model because it's proprietary. But the thing that made the model so good was just the zip code, because it's that simple, right? If you're living in an urban area where you're in substandard housing and there's mold, or there is pollution because you're by the highway, your incidence rate for asthma is way higher, and you're going to get hospitalized for it because, by the way, you go to the hospital because you don't go to a PCP because you don't have a PCP, right? It wasn't rocket science. It was literally, where do these kids live? Yeah. And we were so excited about that, but I don't know that we've made huge leaps beyond that in the last decade. Yeah. And I think we need to do that, and that's part of Centene, I think, has a bit of a moral imperative to as an incumbent in the space, lean in and try to help figure that out.
Yeah, Maybe we've gotten better at marketing and all using the same buzzwords, so it like sounds a little bit better, but,
Yes.
but possible that it actually has not. I know CMS recently was talking about, do you shift even risk adjustment to just an area deprivation index, right? Because interestingly enough, that hasn't happened for the last 15 years when Humedic was identifying that, so definitely. We got to talk a little bit before kind of about your thought process around being in a company that has the basis of a lot of roll-ups of other companies, that you've had a number of different transactional systems, and how you're thinking about that from the perspective of creating a space where you can actually get access to all the data and have better view into the overall population. Share a little bit about kind of how you're thinking about that, how you want it to look in the future, and how you think it will impact the way Centene is able to provide for your population.
Yeah, so when I had the conversation with Michael Neidorf when he was recruiting me, originally into a technology strategy role, I talked about this vision I have for how, healthcare, will over time, I believe, follow the trajectory of financial services in terms of, data liquidity and information asymmetry and automating the back end and all this stuff. So, I had this like beautiful picture, and he's like, yes, come do that at Centene. We are a technology company that does healthcare, and we serve the most vulnerable Americans. And I'm like, yes, great, let's do it. And I showed up the first day, and I walked in, I sat down with Brent Layton, who's been with the company for 18 years, built many of the health plans from scratch, is sort of the father of Medicaid managed care. And he's like, so what do you want to do? And I'm like, I want to do all of these things. And he's like, no. First, you need to figure out how to pay claims. And I was like, wait, haven't you figured out how to pay claims? And the reality was that, a lot of Centene's growth in the early years was organic. And then I joked that we swallowed 3 elephants in the course of 7 years, and we're still in the process of digesting that. But we're certainly not alone in that, right? Like the reality is that the technology ecosystems of many of both, honestly, provider systems and payer systems, right? Is like there's just been a lot of consolidation. And not always just given the complexity, not always the discipline to harmonize the systems. We have an interesting challenge in that the claims platform, or like core transaction platform for Medicaid and Medicare and Marketplace, are actually the best ones, are sort of more fit to those products, right? And so it's not like, oh, we'll just put it all on one. It's like, I can't actually put it all on one. So one of the things that I've spent a lot of time over the last 2 years is trying to figure out, do you create sort of like the death march of platform consolidation? We're going to jam everything to one. There's some like holy grail, right? You don't go build the holy grail. I know that. There are like many, many dead bodies along that road. But what should we be investing against? And so my view of this is actually the same way that I see the end state framework for the whole industry, which is we will always have transaction systems, and they will always become obsolete. And so trying to allow transactional systems to own the interactive space is just a terrible idea, where you set yourself up always for failure. And so how do you like open the crowbar on the back of the transactional systems, epic, and then like free the data, right? And then get the data into a place where you can normalize it, right? And increasingly we have to get to a place where the technology is smart enough that it can normalize that data without humans touching it. And it can do so in a highly precise and auditable way that will hold up to scrutiny at the level of regulators. And then you invest in an ever evolving sort of interactive layer, right? And so that is the picture that we've drawn for Centene, because the beautiful thing about that is if you build that way, then you can evolve as the data evolves, and you can integrate and disintegrate the transactional systems without creating abrasion for your users. And you can create a seamless user experience. So if I have a care manager or a claims expert who's sitting in Louisiana and is sitting with 3 lines of business that they're managing, and all 3 of those lines of business are on a different system, like they are swivel chairing in like endless circles until they call me and say, I hate our technology. But if the data's there and the user interface can just be built on top of it, they don't have to know. I could have 40 claims platforms, right? Some of our competitors do, and you just never know. So it's a bit of that is our North Star, I would say, for how we're building.
I think it's interesting too, right? Because we see this dynamic in payers. We also see it in providers, and yet we do still have the largest holders of clinical data making announcements that we should have a national database, right? Or that it should all be consolidated. And the answer does come down to, even when you do that, we still won't have true national consolidation. You still won't have true full system consolidation. And so if we can figure out how to solve the problem for the users, for the data layer that we need, it does make a lot of sense to kind of lean into that pretext. Is there something that you have your eyes on as like a big win as you think about this new role at Centene, where you are, where you want to be in the future? Maybe it's not even like the biggest, shiniest win, but the thing that you feel like makes kind of the most impact or signals your success.
There are a lot. So there are two, I would say there are two. One is like very specific to the company and where we are today, which is what I talked about earlier, that we have an unbelievably mission-driven workforce, right, that shows up every day because we serve the most vulnerable patients and members in the country. And figuring out how to like be a Fortune 26 company that, you know, that sort of creates value for all our stakeholders and has grown into our size and scale without losing that is like the thing I have my eye on the most. From a data perspective, and they're not actually disconnected, I think, you know, this idea that the industry needs to change, and we all, I mean, I heard Gotti earlier talking about this, right? Like, no more paper, we got to get to digital, we all want to be there, we're all here because we're excited about that. But how we get there, it would be really easy for us to build how we get there, again, in like a commercial model and in a commercial financial framework. And the reality is that if we can figure out how to bring that infrastructure and have it be efficient in a Medicaid framework, we will have solved literally the hardest problem, and everything else will be easier. And so how do we build that data infrastructure, and how do we create like the most efficient automated back-end administration of healthcare so that we can put all of those extra margin resources, right, which in Medicaid are tiny, every dollar of those into a fundamentally different member experience and like innovation around health outcomes. And that's sort of like a microcosm, but against the population that we care the most about, of where I think the whole industry can go, which is when you automate the back end, this is what financial services did. When you automate the back end transactions, the thing that you're able to solve by doing that is the information asymmetry, right? There's huge information asymmetry in healthcare right now. There's so much information that sits with the provider and no information that sits with each one of us as we're making healthcare decisions, right? Same way that, like, you know, 40 years ago, you weren't like going on and trading your E-Trade portfolio, right? But the willingness of members and of patients and the demand of patients to have agency in their journey is only increasing. So you've got to get to a place where you're not putting all your dollars on like transactional systems and data. You can put all your dollars on like, how do I give you the information from that data that allows you to make the 80 decisions you make every day that drive the health outcome versus the one that I as a provider can sort of weigh in on.
Right, right. And that is really a win for everyone who's involved. It's not just for the payer, it's also for the provider, it's also for the patient.
Right.
Which
Everyone
is
sits in their in like their highest and best use of their space and of like the control they have over the factors that influence the outcome.
Definitely, definitely. So there's big, fun, flashy data problems, AI, machine learning, and then there's kind of this foundational transformation that we have to do inside healthcare. For folks who don't know, we at SciOx, Datavant printed and mailed 70 million pages of medical records last year. Like, that's a very stark difference.
Can we all just pause and cry about that for a second?
Should we just blame HEDIS? I don't know if Brad's here in the room.
Yes, just so we're clear, that's the answer to this. I fundamentally believe that's actually the answer to this, if you digitize HEDIS. So I have this theory, right, that like that is where the lifeblood of so much of the system flows, whether you like it or not. And the issue is that it's a moving target because it's like specifications that are written down on paper, and then it's more paper that's going on top of more paper and all of this paper. And if you said, we're gonna literally put it in code, then all of us could actually build infrastructure against a fixed target that was digital and was auditable, right? And then you stop pulling paper charts, you pull electronic charts because the transaction systems will shift to support that infrastructure against a fixed target. And then you're running billions of dollars through a proof point that this whole thing can be digital.
Yeah, and Sarah reminded me that she had said this exact same thing in a room in Boston probably 5 years ago at this point with Administrator Verma.
And she looked at me like I was smoking crack, so anyway.
In retrospect, she probably didn't realize that for some reason we still did not have digital HEDIS measures. Here we are 5 years later, same situation. In the context of these like crazy problems that we can solve with AI, machine learning, even like hyper on blockchain, and then the fact that there are these basic fundamental things that we cannot do if they're not on paper, where do you fall in terms of how you think about prioritizing what you're working on, where you're investing, where the company is thinking about kind of that spectrum?
Yeah, I get really, really impatient about the fact that we're not where we need to be or could be, but I also take some level of solace, especially in my current role, over the fact that we are actually in early innings. And I have an opportunity, Centene has an opportunity to build to that North Star and organize ourselves in some ways by not making the investments that we could have made 10 years ago, right? When there wasn't automated normalization of data or NLP that would hold up to RADV audits, right? That the technology has been catching up. And so like there wasn't Snowflake. Yeah. Right? Like, so our being able to make thoughtful design bets against that future target is sort of what makes me feel like, okay, we're going to be prepared. And then the other piece of it is the advocacy. Like, I fundamentally came to Centene. I spent my whole, I joke, people are like, you have a different background than most people in managed care. I'm like, that's because I spent my whole career trying not to work for a payer. Whoops. But I came to the conclusion after spending 20 years in startup and growth company that the industry needs incumbents to change, right? And so we can be in a position to actually like literally shoulder into some of that change. And so it's sort of a yes and, like where can I be up here saying data, let's go faster, let's be digital, meanwhile building sort of the thoughtful infrastructure so that we can like be a proof point of how that works and invest in the companies that are through partnership, right, not ownership, through partnership that we think are making the right moves and actually sort of amplify the trend over time.
Yeah, I agree with this so much. I mean, I think the big incumbents in healthcare have been here. They will continue to be here. There's fundamental transformational change that can be done within them, but most of them won't move. Like they won't be disrupted as a whole. And so there is this interesting opportunity. I mean, it's why I'm at SciOx or came in through SciOx is specifically because of that there is this really interesting opportunity for us to make change in the spaces that exist today. And I think Centene's also a great example of that. When you kind of think about the various parts of the country and the population specifically that you're wanting to invest more in or are more concerned about in terms of your population overall, is there something specific that's standing out to you, or is there something more that you need from data to be able to help kind of inform that?
It's a good question. I think, particularly for the complex populations, whether it's Medicaid or LTSS, or our like the DSNP programs. I go back to this idea that the way to really serve those populations well is to actually invest in. My interest in healthcare was sparked by a couple of different things, but all anchored in different versions of early sort of social determinants and health equity work. But I spent time shortly after I graduated from college supporting the team at the Harvard Institute for Global Health, where Paul Farmer was, and this idea that he and his team proved the fact that you could have better healthcare in a third world country than we had here in the US by investing in and activating the community around an individual patient or a member in our case. And so I think about the idea that that is the right model of care, and how do we invest in that activation? And we were talking about this as a leadership team last week, and someone said, well, but we don't get paid for that, right? Meaning we can't put the Medicaid dollars to that as part of the program. And one of the things that I think we need to increasingly be talking about is how do we help the states actually understand that the calculus of healthcare needs to be the calculus of health, right? And that they have state budget dollars that are sitting in places other than the Medicaid budget around transportation, housing, right? Community-based resources, social services, that if you blend those dollars and allow them to be directed at, again, the drivers of health in addition to the health care, you will have a fundamentally different outcome for those populations. So that is sort of a longer term conversation, but to do it, we have to prove it, which means we need to get the data to show what we all know from being local and actually seeing it play out.
Yeah.
And so that is that's like saying, let's take on the complexity of healthcare data and then add the complexity of social services data and just solve all the world's problems, or drown in messy data. But I think on a small scale, being able to cleanly show that and then scale that, I think is a really interesting opportunity.
Yeah, I think we heard a little bit about kind of the same framing in the context of public health, right? As a country, we're either activated or we have decided we really hate the government. Kind of depends on which party you fall in here.
There's no middle ground.
But really activated around this concept that actually we need public health and we need all these pieces that surround public health inside a local government or a state-based government to say, how can we do preventative measures, even if it's against just the COVID-19 pandemic, but in the future, when we actually think about broader health problems in that same context.
Yeah, I mean, I think living through, there were two terrifying things for me about living through COVID. One was just the tragedy and sort of the terrifying experience, right, of being in a pandemic and then being stuck home with my kids. And then the other one was watching the world talk about healthcare data in this really painful, uninformed way with not just huge gaps in the data, but not a way to actually understand basic concepts, right? How do you normalize the data? What is a denominator? How do we help people understand what's really going on here? And then how do we get access to data so we know what's really going on here? And it was one of those sort of pessimistic moments of wow, we just have a lot of work to do.
Yeah. I couldn't agree with that more, right? And I think it's such a mirror of the way we look at healthcare in general. I remember realizing HHS doesn't have some actual scoring or dashboard that tells us about the health of the country. We're making policy decisions off disparate sets of data, including lots of missing data, lots of opportunity there. So just to close out, if you have to say the one thing that you're most excited about in the next 5 years for Centene and overall in healthcare, what are you looking at? What are you excited about?
So it's healthcare, so add 5 years to the 5 years, but
15 years to be conservative.
I'll still be there, but no, I mean the thing I'm most excited about is the idea that we have an opportunity to leverage data to fundamentally change the system along a number of different vectors, and that by doing so, we fulfill, it's not like just some side project or like, oh, they hired some technologist to run the company and now we're off like doing a data project. It will fundamentally fulfill the mission of transforming the health of the communities that we serve.
Yeah, love it. Awesome. Well, thank you so much for joining us.
Thank
This was
you.
so wonderful.